that is present on that particular area of the face. We call them as parotid region, which is just under this zygomatic bone or zygomatic arch or anterior to this tympanic plate or tympanic plate of these tympanic plate of this particular temporal bone, which is lying here. So roughly having a shape of inverted pyramid. It has a base, it has an apex. Apex is downwards and base is upwards. Apex is downwards towards the neck region, base is towards this particular zygomatic arch. And it has got anterior border which is visible, and it is having a posterior border as well, which is related to the sternocleidomastoid. Now this anterior border and the posterior border can easily be identified by the presence of this particular duct. We call them as parotid duct. So whenever you are just going to see these particular borders, there are two borders are there, which you can see superior border, anterior border and the posterior border. Anterior border can be identified by the presence of the parotid duct. Now if this particular parotid duct is missing on this particular specimen, which you might have some of the specimen you don't have this particular parotid duct, as a viscera we cannot identify it properly. So it should have a parotid duct to identify as a viscera whenever it is given in the examination. Now besides this particular parotid gland, which has got general features, it can be divided into superficial and temporal. Superficial and deep parts of the parotid gland. Superficial is superficial to the skin and deep is deep to this particular skin in a way which is lying deep to this particular muscles. So this parotid gland is resting on this particular muscle, we call them as masseter. Now on the top of masseter, if it is the gland which is getting deep inside this particular parotid, deep inside this particular masseter, we call them as deep part of the parotid gland. Now apart from that, there may be a fragmented part of the parotid gland lying along with this particular ducts. So if you see any kind of parotid duct or parotid gland which is fragmented out and hanging by this particular parotid duct and close to the zygomatic bone, we call them as accessory parotid duct, accessory parotid gland. Now coming to the contents of this particular parotid region or parotid gland itself, it is pierced by three structures. It has a nerve superficially, we call them as pharyngeal nerve, which is branches of it. Then deep to that we have this vein, we call them as retromandibular vein, which is lying posterior to that, and even further we have a artery which is known as the external carotid artery. And this particular area on to deep, further deeper we have this particular masseter. If you remove the masseter deep there, you find this particular buccinator which is lying deep to it. So it's a kind of like a larger salivary gland. Amongst this particular three salivary gland, we have the mandibular, submandibular, sublingual. The parotid is a serous variety of this particular salivary gland, and this particular parotid is covered externally by a fascia. We call them as parotid fascia. Parotid fascia is continuous with this particular investing layer, and this particular parotid layer blends with the fascia covering this masseter. We call them as parotidomasseteric fascia. The parotidomasseteric fascia attaches to this particular bony areas of this particular zygomatic arch along with the tympanic plate, etc., etc. So this particular parotid fascia or parotidomasseteric fascia is a tight lying structure. That means it do not have much of space existing between this particular gland itself and this particular parotidomasseteric fascia itself. So that's why if this parotid gland enlarges by any chance, it is pressing on this particular like fascia, and eventually it becomes very painful. So that's why there are some kind of explanatory question comes here that explain why this parotid gland enlargement leads to this particular painful situations. So because of the tightness of the parotidomasseteric fascia, which is extending between this particular neck from the mandible to this particular zygomatic process back inside this particular region, we have this tympanic plate and this particular zygomatic and this like mastoid bone. We have a tight line parotidomasseteric fascia, and because of having this tight line parotidomasseteric fascia, we cannot accommodate any kind of expansion of the parotid gland. Whenever this parotid gland enlarges, it becomes painful. Now this particular parotid gland, as I am saying, if it is having a detached part holding between the zygomatic process and this particular duct, we call them as accessory parotid gland, which may be present, and deep parotid gland, which is lying deep side of it, which is maybe split by this particular zygomatic process or mandible as well. So it is resting on the mandible, ramus of the mandible. So if you have any parotid gland lying deep to the ramus of the mandible, we call them as deep part of the parotid gland, and rest is superficial parotid gland, which you are seeing here. Now these particular structures, as we are mentioning, these are the structure that is running through the parotid gland. Superficial to deep, you have to memorize them. This is the most important part that you should remember. Most superficial structure that is present within this parotid gland is the facial nerve, which you can see splitting into 5 branches. We know the branches, and then we have this vein which is coming over here. We call them as the vein joining over here. We call them as superior temporal, superficial temporal vein, which is joining with this vein. We call them as transverse cervical vein or a transverse facial vein, and as well as this particular superficial temporal vein joins together, forms a vein which is going on the back side. We call them as retromandibular vein. So retromandibular vein, which is lying in this particular region, receiving the tributaries, runs into the substance of the parotid gland. Even deeper, we have this external carotid artery, which is running in, splitting into 2 terminal branches. We call them as maxillary artery and the superficial temporal artery. So these are the 3 structure that is present in superficial to deep. We have this nerve, then we have the vein, and then we have the artery, and on top of that we have a lymph nodes which is present deep inside, present to it. We call them as parotid lymph nodes or parotid group of cervical or cervicofacial group of lymph nodes. So the structures embedded within this particular, like a parotid gland, partially of course, we call them as this particular facial nerve, then retromandibular vein and external carotid artery, and even deeper we have the lymph nodes. So this is what you have to keep in mind. Coming to this particular outlet of this parotid gland, the secretions of the gland comes through the duct. We call them as parotid duct, also known as Stensen's duct. Length approximately 5 centimeter. It comes from the anterior border or middle part of the gland, anterior border of it, and runs across this particular masseter and then dips into this, piercing this particular muscle deep inside. We call them as buccinator, and then opens into this part. We call them as vestibule of mouth against the opposite to the crown of the upper second molar tooth. So this particular element is important because this opening can be seen inside the oral cavity or buccal cavity. We have to inspect that in some of the patients if required. So this particular parotid duct, Stensen duct, comes as a short note. Many times we've seen that, which is the outlet of this particular parotid duct, and of course this particular parotid duct attached to this anterior border gives a clue to identify the anterior border of this parotid duct. So in a specimen, if you do not have this parotid duct, we cannot identify it properly. In living conditions or in cadavers, of course we can identify, but if it is removed parotid gland without having this duct, we cannot actually comment on it. Now this, on top of this particular parotid duct, we have a branch of facial nerve which is known as buccal branch. It has 2 splits, upper buccal and lower buccal, runs across. On superficial plane, we have this particular transverse facial artery and transverse facial vein which runs into these particular regions, which comes in the relationship with this particular parotid gland. And as we are saying, this particular parotid duct is piercing obliquely through this buccopharyngeal fascia and buccinator muscle, obliquely going deep inside. So that creates a hinge so that this particular saliva is not flowing retrogradely. So if the grow or the flow of the saliva from the gland to this particular oral cavity and preventing the reflux or return of the saliva from oral cavity to mouth because of this obliqueness, that means it is curved in that region. And where does it open? That point you have to keep in mind: vestibule of mouth, crown of the upper second molar tooth. Blood supply to the gland comes from branch of external carotid artery which is running through this particular gland itself, drains into the blood into this external jugular. Lymphatics grows to this parotid group of lymph nodes, which is eventually grows to deep cervical group of lymph nodes. Nerve supply, this is important to this. There are 2 different types of nerve supply whenever you glands we are considering. One is motor supply, other is sensory supply. So here we call them as secretomotor, that means secretions part is controlled by some gland, we call them as parasympathetic nerves. So this parasympathetic or secretomotor comes over there, which comes from the cranial nerve number 7 or glossopharyngeal. Via branch we call them as lesser petrosal nerve, which runs along with the nerve, we call them as auriculotemporal nerve. So, this nerve supply or the secretions of the gland is controlled by this glossopharyngeal nerve. If it is stimulated, it secretes. If it is not, then it is not coming with the secretions. Opposite to this sympathetic, we have the parasympathetic, we have the sympathetic, which is coming from the cervical ganglia, which is basically this particular cervical plexus, which is running around this particular external carotid artery, which is giving a tweak to it. And touch pain temperature, of course, coming to the facial region. On this region is coming from a trigeminal branch, which is known as the auriculotemporal same nerve, with great auriculotemporal nerve carries the branch from this particular V3. That means the mandibular divisions of the trigeminal nerve. So, this is a summary of the things like this. We call them as the auriculotemporal nerve, which carries the fibers which is leading to this particular gland, supply the secretomotor, which is coming from this cranial nerve number 9 or glossopharyngeal through a branch. We call them a tympanic branch, which makes a plexus in the middle ear. Then it gives a twig, which is known as lateral pistral nerve, which relates to a ganglia. We call them as otic ganglia. Then it postganglionic fiber comes over here. We call them as auriculotemporal nerve, runs to the, which is a branch of third division or V3 division of the trigeminal, supplies this secretomotor to this particular gland. That means this gland is carrying the secretory fibers. So, if by any chance this fiber are deranged or damaged, we have a secretory problem to this particular gland. Coming to this particular nerves which is running through it. So, we have this parotid gland pierced by this particular nerve, which is having a branch above down. We know the names. Important out here is the buccal branch, which has upper and lower divisions, runs along above and below this particular parotid duct. So, that particular branch you have to keep in mind whenever you are seeing. And apart from that, you have temporal, zygomatic, marginal mandibular and cervical branches above down. These are the branches, and remember that they are motor branches. They are supplying the muscle of facial expression. They are nothing to do with the sensory supply. Now, this particular region, this is the same illustrations of the thing which you are seeing here is the temporal division. Then we have the zygomatic divisions on this cheekbone. Then we have the buccal branch, which is having upper and lower divisions. Then you have the mandibular. Then you have the cervical branch, which is going to supply the platysma. Of course, these are motor branches of facial nerve. They have nothing to do with the supply to this particular gland because they are running through this gland substance. We have to remember them. Coming to this particular clinicals, which is related to this particular nerve where it is passing through. Now, this particular nerve, facial nerve, if it is cramped at any point as it is coursing through this particular stylomastoid foramen getting into this particular gland itself, it may be cramped or it may be compressed at any point. Then it creates to this particular problem of the nerve, we call them as palsy, where the nerve is not functioning properly. This kind of nerve palsy, we call them as Bell's palsy. This Bell's palsy is a kind of palsy which is involving the facial nerve. Now, if you involve this facial nerve of that side, that particular nerve is supplying this muscle of facial expression. That's not going to work. So, this particular facial muscles of that particular side will be paralyzed, and these particular things we call them as Bell's palsy, which is the 7th cranial nerve palsy, which is involving these divisions which you are seeing this particular gland, which you are seeing in this particular glands which is running through it. So, this particular nerves which you are seeing here, this facial nerve, if it is cramped by any times, it can not function properly. It is not going to supply the muscle of facial expression. So, that particular side, if it is right side, left side, muscles of the facial expression is not going to work. And that thing we call them as palsy. We call this palsy as palsy of the facial nerve, Bell's palsy. And most of the times we see that they do not find any clue or any reason for this palsy. Viral diseases or any kind of compressions might have happened or may not find any reasons for it. That's why you call them as idiopathic conditions of involving this nerve cramming. We call them as Bell's palsy. Now, coming to the clinical correlation thing which you have to understand, this facial nerve is covered by a fascia. We call them as parotidomesenteric fascia, which is deep type line. So, if any times this parotid gland having infections, it swells, enlarges. So, if it enlarges, we do not have much space. So, this particular enlargements of this particular parotid gland presses on this particular fascia, and this particular fascia, on top of that we have this particular like branches of this particular trigeminal nerve, which is V2, V3 is supplying this face region and compresses those particular nerves along with it. So that leads to these particular nerve irritations, and those nerves are if irritated, it becomes immensely painful. So any swelling of this particular parotid gland cannot accommodate any types of like expansions. That leads to these particular conditions. We call them as parotid swelling, and parotid swelling is a very painful condition. So explain why this parotid swelling is immensely painful in a patient who has viral parotides or parotid abscess or parotid infection, etc., etc. So these kind of things is a kind of important explain why kind of questions. Why parotid swelling is painful? That's why explain with your anatomical knowledge. Another thing, the duct itself. So the duct which is carrying this particular saliva, which is draining into this particular like part of this particular oral cavity, we call them as the vestibule of mouth, opposite crown of the second molar tooth. Now this particular duct may be occluded by obstructions by some kind of stones inside. So a stone inside this particular duct which may block this particular parotid duct flow. That means the saliva is not flowing anymore and leading to this back pressure to the gland itself. Again it is going to swell this gland. So that particular thing we call them as a calculus or stone within this particular duct. So if you have stone inside, either you have to crush it or you have to do a surgery to remove that. We have to diagnose it with this particular dye pushing through it, just like we place the dye in this IVU or venogram or renogram kind of things. We put it right through this particular opening here, again second mouth, vestibule of mouth, second molar. We are finding the opening, throw the drug and see this particular dye, how it is staining this particular duct. So if you see number of these particular constrictions and these particular like spikes are there, that leads to these formations of this particular calculus in it. If you have this particular calculus which is been visualized by this radiogram, we call them as sialography, then we go for surgical removal or surgical corrections to it. So these are the things that you keep in mind regard to clinical correlations of the things. Now before that, if you have a tumor of this parotid gland, it need to be removed. If it is a superficial tumor, if it is a deep tumor, depending on how much parotid gland you are scooping these things out. Most of this particular tumor involving this parotid gland in the superficial region. Again, if it is a tumor, grows slowly, stretches on this particular thing, which is like allows some kind of stretchability. If it is an acute swelling, it becomes very painful. Now this particular tumor, if you are just like operating on, whenever you are doing surgery, you have to be mindful to the nerves or the arterial or these particular structures which are running through this particular gland itself. So whenever you are doing surgery onto this gland, you have to be careful about the nerve which is running through it. You have to be careful of the vein and arteries which are passing through them. So these are the things related to this particular parotid gland that you have to keep in mind. So it has a base, it has an apex is downwards towards the neck, base is towards this particular cheekbone, it has a superficial and deep part. Superficial is superficial to the skin and deep is deep to this particular region, and which is lying ramus of the mandible, which is lying posterior to the ramus of the mandible or deep to this particular masseter. This particular parotid gland is resting on this muscle, we call them as masseter muscle, and deep to that we have a buccinator. Parotid gland has a duct which is crossing this particular masseter, then it runs obliquely, pierces this particular buccopharyngeal fascia and then pierces buccinator muscle, gets into this vestibule of mouth, opens into the vestibule of the mouth, again second crown of the second molar upper side tooth, and that particular opening is an important landmark and we understand why it is. Parotid is covered by a fascia, parotidomasseteric fascia, immensely tight, doesn't allow any stretchiness or expansions of the gland. If this gland is kind of like expand quickly, rapidly, it presses on the nerves which is present on top of it and irritates and becomes immensely painful. Now this gland is having this particular structures which is running through it. If you have any tumor, you have to be careful not to damage them. If this particular facial nerve running through them by any chance is occupied or kind of cramped or any kind of damage, it can lead to the palsy. That palsy we call them as Bell's palsy. Now if you have duct tumor or duct growth or duct stone, we have to deal with accordingly. And this particular parotid gland receives the blood supply to this particular artery, drains to the external carotid artery, and secretomotor, that means the secretions of the gland, is controlled by ninth cranial nerve through the auriculotemporal branch, and it also have the sensory division which is coming from this trigeminal nerve V3. That is why this particular gland is painful whenever it is stretched on, and sympathetic division comes through the sympathetic plexus or sympathetic trunk. So, this is all about this particular gland in short, that we have to understand, that we have to know about. So, these divisions of the branches that you have to keep in mind. Branch of which is supplying through this particular is glossopharyngeal nerve, through the branch it is reaching here auriculotemporal nerve. So, there is another clinical conditions, we call them as Frey syndrome, or also can as salivary syndrome. So, if you are doing any surgery, this gland, this particular gland, this auriculotemporal nerve can be damaged or may be damaged. So, if it is damaged, and then nerve regeneration happens. So, sometimes there is a faulty regeneration of the auriculotemporal nerve with this particular sympathetic nerve. So, see, auriculotemporal nerve may grow into the sympathetic nerve. Now, sympathetic nerve supplies the skin and supplies the skin sweat glands. So, sometimes it happens post surgery, we see that whenever the patient is taking a food, instead of salivation they are sweating. So, this kind of thing we call them as Frey syndrome. So, when this patient is taking food, it should be salivating. Secretomotor nerve of the parotid gland should be stimulated, which is going to make a secretions to it. Now, if you have a botchy surgery which happens post parotidectomy, the auriculotemporal nerve may be mingled or may be accidentally joined with this particular sympathetic branch, which is going to supply this particular gland, sweat gland, sympathetic fibers of the sweat gland. Now, instead of that particular branch secreting this particular parotid gland, it is secreting sweat. So, this kind of thing we call them as Frey syndrome. So, whenever you see this kind of patients, they have a vasodilation and sweating instead of salivation. It happens post surgery because of the faulty regeneration of the nerve fiber between the sympathetic nerve fibers and auriculotemporal nerves. But it is a complex thing. I do not know whether you can digest this thing at this level or not. So, parotid gland swelling and the Bell's palsy and painful nature of this parotid swelling, that you have to understand, that you have to know. So, whenever you are seeing this particular parotid gland, you have to identify this particular parotid gland given to it. So, base is upside and this particular apex is downside. So, whenever you have this particular parotid gland, external side and internal side you have to identify. External and internal side of this parotid gland is identified by this particular side over here, we have the pinna. So, usually we, or most of the times, we pick up this particular parotid gland, keep this particular pinna or external acoustic meatus or external auditory meatus, which is present at a part of it. So, this external acoustic meatus is present on it. So, that means this particular area is external side, and then this leaves this one is internal side. Then that means this side is the superior part or superior border or above, and this is apex, which should be pointing down. So, this one should be placed laterally like this. Now, then we have to identify this duct which has to be present in the anterior border. If you do not have this particular duct present in this particular gland, which this particular gland has, because the ducts are there but been removed or stripped because of the frequent examinations. So, we cannot identify which is anterior border of this gland and posterior border of the gland. But assuming this particular gland is a parotid gland and this one is the anterior border, superior border, posterior border, this is a posterior side or interior side, this has to be external side. So, parotid is present on the lateral side of the body. So, you have to hold this particular anterior border, this particular border should have this parotid duct, should be placed like this. So, anterior border facing anteriorly and posterior border facing posteriorly, and this opening of this external acoustic meatus should be placed on the lateral side. So, this opening should be on the lateral side, this is the posterior border, this has to be anterior border theoretically, but it should have this particular duct merging from this way. This is above, this is below, this is the base which has a nerve which you can see, this particular facial nerve which is tweaking down here, so which is present in here. So, apex, base, anterior border, posterior border, superior border, and this is the lateral or external surface, this is internal surface. Lateral and external surface identified by this external acoustic meatus or the ear or the pinna itself. So, you can also see that most of the specimen have this particular pinna or external acoustic meatus inside to it. So, this is the lateral side and this is the medial side. Anterior border, posterior border is identified by the presence of the duct. If you do not have them, it is a problem which is difficult for it. So, during examination, if it is there given in examination, we cannot properly. So, you have to prepare a new specimen for the examination if we have to give you as a identification of gland, or else this particular gland can be given in specimen as well. So, we can just like tag this particular gland itself by in the specimen by putting a mark on it and identify several questions. We can identify the duct itself. Ducts can be identified as a parotid duct, which can be exam tags as well. Facial nerve as well can be tagged in examination in the face along with that. So, these are the things that is present, and then you can see this particular number of blood vessels and structures that is running through them. And if you just like cover this particular external surface of the parotid gland, this is a thick fascia which is present in it. So, this is a parotidomesenteric fascia, which you can see that thick fascia is there, and then we have the blending of this particular fat tissues in it. So, this particular region is a kind of important, and back side you can see the strip of this particular mastication muscles also part of it, which is a masseter which is present in here, present in it. You can see the blood vessels as well present in piercing through this region. So, these are the branches of this external carotid which is present in it, and this, if you see any veins, that has to be branch of the retromandibular vein, and nerve, if you are seeing in here, has to be facial nerve. Now, glossopharyngeal nerve, you cannot see that because there is a tiny branch supplying this particular gland, auriculotemporal nerve. So, remember that during examination, the catch is that whenever you are identifying this, they ask you about the nerve supply to it, and we often say that this is a facial nerve which is supplying to it because it sticks to our brain, that is passing through it, it is going to supply. Facial nerve is not going to supply this parotid gland, is a secretomotor, it is supplied by the 9th cranial nerve, also known as glossopharyngeal. Glossopharyngeal, where is the glossopharyngeal? You see that? We cannot see that because this is a tiny branch of glossopharyngeal, we call them as auriculotemporal. Even tiny branches, they are going to supply this. We cannot see that in a specimens. What you can see, the structures of the nerves which is traveling through it. What nerve traveling through it? Facial nerve or branches facial. Then what the facial nerve is doing out there? It is passing through. It is not doing any business out here. So, it is just traveling through that particular gland, piercing and splitting into branches. What is going to do with this particular branches? It is going to supply the motor branches to facial muscles. It is not going to do any secretomotor or supply to it. It is supplying the muscles of the face, not the skin of the face again. So, we get mixed up during this particular number of things in the face regions with this facial nerve, glossopharyngeal nerve, and this trigeminal or branches of trigeminal. So, these are the catchy things that you keep in mind. So, this is about this particular gland, and the theory of it is important, explain why is important, and practical. If we get a specimen of this particular parotid gland with the parotid duct, we will give that in examination for identification. If it is not, we tag it in cadavers.